antibiotics. And I think in the future, how can we make the right choice? I think we need to have more MDT efforts to clarify the best standards to guide our choices. And this is not only for the intensive infection patients, but also for patients that have the resistance issue to different antibiotics and also drugs choice for resistant strains. I think with tonight's meeting, with a joint discussion, we can have better understanding as how to better utilize the antibiotics in the future. I also want to wish today's meeting a great success. Thank you, Professor Liu Shao, for your wonderful opening remarks. Now I'd like to invite Professor Xin Jingyan to give us the opening remarks. Professor Xin is from the Qingdao University Affiliate Hospital, medical doctor to physician, doctoral supervisor. She also has many other important academic titles. Over to you, Professor Xin. Respected Professor Chu, Professor Wang, and I don't have good connection because I'm not back to my room. So first, I want to thank Professor Chu for the kind introduction. It's my great honor to attend this meeting together with other top experts. And just now, another professor sent me a text message. President of Italy visited China, and he's gonna spend 6 days in China. So I'm very happy to have the joint discussion with Italian expert online today. The intensive infection or severe infection is a very critical issue in our department. Facing different patients, we will have different treatment choices. I hope that through tonight's meeting, we can have the learning from each other, and we can also have the mutual learning from each other in the future. We can also conduct more collaborations. I sincerely hope tonight's meeting can be a great success. Over to you, Professor Chu. Thank you, Professor Xin, for your kind opening remarks. Without further ado, we will enter into the academic part. The first speaker is Professor Carlo Tascini. He's going to give us an academic talk. I'm going to introduce him to you. Professor Tascini is from the University of Woody Medical School, full professor in infectious diseases, and he is director of the specialty school in the multi-infective, the medical internship program, director of the infectious disease clinic. Welcome, Professor Tascini. And today he's gonna share with us about the case of SSTI. Over to you, Professor Tascini.
So, Professor Q, thank you very much for the invitation. Can you hear me? I asked, yes, okay. I try to share my screen. Let me share my screen. I hope that you can see well the screen. Okay, can you see are you able to see the screen?
Yes.
Yes, so I'm Carlo Tascini. I'm a professor of infectious disease at Udine University Hospital, northeast of Italy. My topic is today a clinical case of skin and skin structure infection. So these are my potential disclosure for today's talk. So I start for this case of a 70-year-old woman that she cares for a person at home and she don't want to move from her home, so she don't look for visiting medical assistant and so on, and so no medical check in the last years, and she suffered from arterial hypertension, and she has intolerance to sugar, obesity, and she has smoked for decades 20 cigarettes per day. You can see that She weighed 90 kilos and the height is 168 centimeters. So started with an erythematous periungual lesion that began at the level of the left big toe, and she was visited by her family doctors who diagnosed fungal dermatitis. And the doctors prescribed topical antifungal therapy that because he believed about a dermatological fungal lesion. But the lesion extended to the entire big toe with edema, erythema, and pain, and the patient reported that the foot is colder. So probably there is an arteriopathy in this more than 70 years old woman that smoked a lot during her life, and also with probably diabetes. So when we start a lesion at the foot, we have to keep in mind that diabetic foot infection may be present. So the patient was taken to the emergency department and sent for the dermatological consultation. At the blood test, there was a leukocytosis with a slight increase of creatinine, blood sugar 150 milligram per deciliter, so compatible with diabetes. And for the other tests, all were normal. So was suspected cellulitis of the foot, and therapy with the levofloxacin 750 milligram per day was prescribed, and the patient was sent back to her home. So when we have an infection of the skin, we have to keep in mind that the tip of the infection is very important, because we may have infection of the superficial part that are milder with respect to cellulitis, and even worse, fasciitis that may be life-threatening, and sometimes the surgical source control is more important than antibiotic therapy. So in this case, do you think that therapy is right? So we have to keep in mind how Staph aureus, that is the first cause of skin infection in diabetes patients in our country, is resistant to quinolones. So we find normally that methicillin-resistant Staph aureus is also resistant to quinolones because of mechanism resistant are bring by some gene cassettes sometimes, and so the MRSA infection in our community, in my region, is around 20%. In Italy, in some part even higher, and quinolones resistance is still high. And in Europe, there are some black box, some contraindication to prescribe quinolones to elderly people for problem related to vascular adverse event of quinolones. So in this case, probably for a patient that did not frequent the hospital, the most frequent pathogen may be Staph aureus or streptococci. So for this reason, quinolones may be a good choice, but also we have to keep in mind how high is the methicillin-resistant rate in your region. So we know that there are several, probably too many guidelines for the skin and skin infection, for skin and skin infections, and MRSA is the most important pathogen in this situation. In the case of diabetic foot infection, we know that there are several classifications also for diabetic foot infection, and among diabetic foot infection, we may have mild infection or severe infection. According to the classification, the most useful is the Texas University classification of diabetic foot infection. This is our experience of 10 years of diabetic foot infection when I used to work in Pisa Hospital in center of Italy. According to our colleague Alberto Piagesi, that is a diabetologist, we follow a lot of patients, and this is the macrobiology of the first visit So patients for the first time came to the hospital with moderate to severe diabetic foot infection. And you can see that 52% of infection in moderate to severe lesion are due to gram-positive, as Staph aureus is around 30%, but also gram-negative are important, like Enterobacterales, 23%, and also Pseudomonas, that was around 10% in this Italian epidemiological series. And the most important thing was that when we check the resistance to quinolones in these patients, you can see that we have more than 50% of resistance in the isolate from diabetic foot infection. So according to this, in diabetic foot infection is very dangerous to prescribe the monotherapy with quinolones. So the epidemiology of skin infection, foot infection in diabetic patients is related to the region where they live. In fact, in high-income country, most frequent pathogen are Staph aureus streptococci. Instead, in low or medium income country, gram-negative are more frequent, especially in a country where the weather is warmer, because gram-negative, especially Pseudomonas, is grow better in warmer climate, and in patients that use to wash several times feet, like people from MENA country or Middle East country. So it's important the epidemiology of infection of the skin in diabetic patients according to the country where they live. But when we isolated MRSA, this is our experience in diabetic foot infection, published in the ECCMID 2015. If you isolate MRSA from one of these patients, the probability to die is higher. And so it's very important to know also this point. And we have always to rule out osteomyelitis, because it's different, the therapy, the length of therapy, the type of therapy in osteomyelitis. And in diabetic foot infection, it's enough to see or to touch with the specillum, the bone. So this is the probe to bone to diagnose osteomyelitis. You don't need CT scan or other examination to confirm the osteomyelitis. So coming back to our woman, to our patients, the patients returned home. The foot did not improve, but unfortunately, after 2 days, traumatic lesion of the left pretibial region happened, and within 2 days, there was a lesion, a necrotic lesion that also has a red border and a erythematous lesion and was warm. So she came back to the emergency room, and now you can see that again there is a leukocytosis. Again was seen by dermatologists that prescribe amoxiclavulanate and macrolide, and returned at home, but the clinical condition worsened and was come back to the hospital, and was seen by a vascular surgeon who detects tight stenosis of the left popliteal artery. So you can see here how the lesion was so severe now. These are the foot. And there was an emergency hospitalization, a first attempt to revascularize the femoral popliteal axis that failed, and so was admitted to the vascular surgery unit, where she arrived with diagnosis of acute left leg and foot ischemia after endovascular revascularization due to critical ischemia with large leg lesion. And so fibrinolytic therapy was instituted with heparin and urokinase, and the following day endovascular revascularization was carried out with mechanical disobstruction with placement of stents, multiple angioplasties, and the femoral-popliteal and peroneal artery of the lower limb and subsequent fibrinolytic therapy. And the piperacillin tazobactam was started. So our way to administer piperacillin tazobactam is a loading dose that is 1.5 dose followed by 18.5 gram continuous infusion. This is the protocol that we use because it's a time-dependent antibiotic, and so you have to stay more than 60% of the time above the MIC. If it's possible, 100% of time, but our target is 4 to 8 time above the MIC to be bactericidal. And we know that in diabetic patients, the neutrophil activity is impaired, so we must be bactericidal. So I realized that there is also a pharmacologist colleague, and this is very important, how to administer antibiotics today, because the efficacy of the antibiotic depend on the PK/PD target in the way that we administer. So you can see here the stenosis of the popliteal artery, and here after the stenting that the artery is not closed anymore. And you can see here the contrast material that passed through the popliteal artery. So unfortunately, the blood culture was positive for MRSA, and also the culture of the tissue of the cellulitis was positive for MRSA and Providentia stuarti. And you can see here the susceptibility test. You can see that this strain is susceptible to ceftobiprole, resistant to cefoxitin and oxacillin. Also, the cefoxitin test is resistant, still susceptible to cotrimosazole, to vanco, take on daptomycin with a high MIC on the European clinical breakpoint, that is 2 for vancomycin and teicoplanin. So in this case, we have to keep in mind that with this MIC, this strain may be heterovisa. So there are some cells inside the colony of Staph aureus that may have a MIC of 4 or 8, and these happen 1 to the 5, 1 to the 6 colony forming unit. So this is this gram-negative Providentia stuarti is susceptible to cephalosporins, and also we have tested ceftobiprole that is susceptible. So we measure normal glycated hemoglobin. Diabetes is not developed in these patients. The clearance of creatinine was 40 because the patient's renal condition was deteriorated due to sepsis. So we started daptomycin according to the renal clearance, 350 milligram every other day, and also ceftobiprole, 250 milligram every 8 hours. In our hospital, we are able to measure in the blood daptomycin level and ceftobiprole level. So we may send 2 or 3 times a week this test, and we have the response in the same day, in the afternoon, and there is a pharmacologist that help us to choose the better dose for his antibiotics. So we know, and we have already discussed in the last meeting with our Chinese colleague, that according to the CISO effect, if we combine daptomycin and antistaphylococcal beta-lactam, we increase the activity of daptomycin because this combination is. These are the conditions of the left leg of our patient. You can see here that probably there is the risk on the foot of osteomyelitis because this necrotic lesion is very, very close to the bone. So according to our diabetologist, we made a scarectomy of the leg, and you can see here that we have removed all the necrotic tissue, and we have the results of a peak serum of daptomycin that was 25 milligram per liter. The MIC was 1, so the ratio was 25. So this ratio is okay for Staph aureus bacteremia and skin structure infection. We know that the peak concentration has to be more than 60 of the MIC. So we have a ratio of 25 or more than 100 milligram per liter. And this is the peak concentration. The trough concentration may be no more than 25 milligram to avoid adverse event. So to avoid the selection of resistant strains, we have to have a better PK/PD ratio for this patient. So we increased the dose of daptomycin. According to MRI, we were able to rule out osteomyelitis, and so we modify our therapy with daptomycin 700 milligram every 24 hours and ceftobiprole 500 milligram every 8 hours. And peak serum of daptomycin was up to 80, so was in the target, and also the concentration of ceftobiprole were in the target. And so the patients were discharged after a month of hospitalization, waiting for a skin implant. So according to the classification, the older classification was complicated skin and skin structure infection. Now we have acute bacterial skin and skin structure infection. That was a definition of FDA, but only for included patients in the registration study. So we have antibiotics approved for acute bacterial skin infection, but this kind of infection rarely are critical and rarely are admitted in our ward, especially intensive care unit. So sometimes we have to use this drug for acute bacterial skin infection off-label. So this is the definition of APSI. But in this definition, no diabetic foot, non-fasciitis, non-Barnes infection. So I can conclude my clinical case saying that there is a number of recommendations of skin and soft tissue infection that are being published, but there is not all are have the same view in the skin infection. The optimal therapy is timely aggressive source control and antibiotic therapy. So we have to distinguish necrotizing from non-necrotizing disease, and this is important to know, for example, the CPK level. Empirical therapy must take in account about the risk of MDR strains, especially in Staph aureus methicillin-resistant strain. Thank you very much.
So just now, Professor Tascini shared with us a case that has the diabetic foot with the infection, and also shared with us many important studies results. And in his talk, we learned that the Staphylococcus aureus infection rate in diabetic foot patient is quite high, which is around 29%. And also for levofloxacin, the resistant rate is also very high, which is more than 56%. So with the combination of the cefalobiprole and the daptomycin, we successfully treated the patient. So for patients that have the abscess as well as the penetrating trauma and the cellulitis, and has the MASA history with the concomitant diabetic food, they are highly likely to have the resistant Staphylococcus aureus. So next, we're going to have the panel discussion. We are also very happy to have Dr. Simona Giuliano from Italy join us. So over to you, Professor Giuliano.
Good. Can you hear me?
Yes.
Okay. Yes, I thank you very much for the invitation. We have just talked with Professor Tascini about this case of diabetic foot infection, and I'd like to stress the importance of adequate antibiotic therapy that is targeted to the probable etiologic factor of this skin and skin structure infection. I would like to also stress the importance of coverage for anaerobic coverage for this kind of infections. So I would like to ask to Professor Tascini what he thinks about the importance of coverage of anaerobic.
So thank you, Simone, for the question. There are cases of skin-on-skin structure infection in which anaerobic are very, very frequent. For diabetic foot infection, not the case in this case that I show today, but sometimes for Texas University classification class 3, we have several indications also to treat, to cover, if you want, anaerobic infection. Instead, in severe skin infection, also outside diabetic patients, there are infections of the perineum that are frequently caused by anaerobes, and also in drug addicts, we have frequently anaerobes involved in skin infection due to drug inoculation. So in these cases, anti-anaerobes activity is very important. So we have to know that daptomycin may be active against gram-positive anaerobes, but not gram-negative. Instead, ceftobiprole has few activity against anaerobes. So in this case, we have to add another antibiotics to increase an anti-anaerobic coverage.
Okay. Next, I want to hand over to Professor Minggui Wang. Professor Wang, any comments or questions?
Thank you, Professor Tascini, for your excellent presentation. And may I have a question first? What's the prevalence of methicillin-resistant Staphylococcus MIC in Italy? What's the percentage?
Yeah. So unfortunately, in Italy, the MRSA rate in blood isolates, we know only in blood isolates because we measure only in blood and cerebrospinal fluid isolates, is around 25% in the country. But there are some regions in our country where the rate is 10% and some regions where it's 45%. But the mean rate is 25%. Unfortunately, this rate is the same in the last 20 years. We were not able to reduce the circulation of MRSA. We don't have so many community-acquired MRSA. We have hospital-acquired MRSA, but I repeat, unfortunately, that the rate is the same in the last 20 years and is up to 25%. There are countries in Europe like UK where a strict infection control in case of MRSA colonization and infection has reduced the rate of blood isolates from 20%, 25% like in Italy to 5% in 5 years. So strict infection control in the hospital are useful if you want to reduce your MRSA, but unfortunately, I don't know how is the situation of a health national system in China, but in Italy it's a public health system, and unfortunately in some situations we don't have the strength to apply all these measures of infection control to our hospital because of shortage of funding.
Okay, I think in study 25% the prevalence of MRSA is already low. It's lower than in China. And in China, we have a similar experience with England. The prevalence of MRSA decreased from 60% in 2005 and decreased to now less than 30%, about 29%. This is also maybe related to the infection control measures implemented in clinical. I have a I have the second question. The susceptibility test showed that although it's MIC isolate, but it's susceptible to ceftazidime avibactam. Oh no, sorry, this piperacillin tazobactam. So piperacillin tazobactam usually for treatment of gram-negative bacterial infection. So in China, usually it's resistant, but how is your experience for the use of piperacillin tazobactam for MRSA infection treatment?
So I understand the question. So we changed to ceftobiprole because ceftobiprole is active against the MRSA, and the ceftobiprole may be active against Enterobacterales that are not SBL or AMP-C. These strains was susceptible to ceftazidime and to piperacillin tazobactam. So we use a lot of piperacillin tazobactam. It's the first drug in our hospital because fortunately we have around 15% or less ESBL in our hospital. So it's the first choice for gram-negative. But in this case, it's a mixed, it's polymicrobial infection, gram-negative and MRSA. According to the activity of ceftobiprole against the MRSA, we change from piperacillin tazobactam to ceftobiprole. So we use piperacillin tazobactam by continuous infusion. And so in the last year, we have data from more than 300 patients treated with continuous infusion, and the medium blood concentration was around 80 milligram per liter. That is 10 times higher than the European clinical breakpoint for piperacillin tazobactam for Enterobacterales, that is 8 milligram per liter. So we use in this way, we use a lot, but when we have the need to cover MRSA, we use ceftobiprole. Before ceftobiprole, we combined daptomycin with oxacillin or sometimes with piperacillin tazobactam, because we know that even against MRSA, if we add a beta-lactam that is not active against MRSA, but the beta-lactam is able to decrease the MIC of daptomycin. But after the availability of ceftobiprole, we use ceftobiprole in combination because it is more potent than other beta-lactam that alone are not active against Staph aureus. I hope that I answer your question.
Thank you. I also learned from you that, happy to know that in Italy, TDM drugs include ceftobiprole and daptomycin. In China, these two drugs have not yet monitored by the therapeutic drug monitoring, TDM. So it's good in Italy.
To be honest, there are very few hospitals that measure TDM also in Italy, but there are also even less in Europe. So this is a possibility that we have in this hospital, because there is a pharmacologist that is implemented this measure using spectrophotometer method. And so it's easy for our lab to have the results in few hours, because we use in the normal lab the spectrophotometer method to analyze many of antibiotics, antifungal, and sometimes antiviral drugs. And so we may able to have the consultation of the pharmacist the same day, the pharmacologist, and to change the dose according to the fact that is too low or too high.
It's very good. Thank you.
Thank you very much.
Can I ask a question to Professor Wang? I'm just curious. I would like to ask you if you have observed in the last year an increase in drug toxicity related to the use of daptomycin at doses between 8-10 milligram per kilo, namely eosinophilia or myopathy. Because we in Europe have seen an increase in drug-related toxicity.
In China, daptomycin is not so intensively used than other countries, because blood culture for MASA is not common, and we usually use 500 milligram per day, and also no hospital is capable for TDM for the drug, so we don't know the level of drug concentration, and the adverse effects is also not so common for this drug. Okay, because due to the use of daptomycin in combination with ceftobiprole, for example, for Staphylococcus aureus bloodstream infection, we can reduce actually the dose of daptomycin. This led us to a reduction in the drug-related toxicity, because in the last 5 years, in my experience as an ID consultant, I've seen a higher degree of toxicity using doses that are recommended for Staphylococcus aureus bloodstream infections, such as 8-10 milligram per kilos. So the combination is also able to reduce the incidence of these drug-related toxicities. So it's very interesting. Yeah. Thank you for sharing the experience.
That's all. I'm sorry about taking too much time of the discussion session. I would like to hand over to Professor Chu. Thank you, Professor Wang. And thank you, our two professors from Italy. We have learned quite a lot. Now I'd like to invite Professor Xing Jingyan. Thank you. I would like to thank Professor Wang for these great questions. I have learned quite a lot as well. In China, in Huashan Hospital, led by Professor Wang Minggui, our epidemiological survey for antibiotics management and also for disease management, I think it's very important. For MRSA, when I was young, we have very high proportion of MRSA, but after these years of efforts, we have reduced MRSA proportion. Now, for the entire China, it's around 30%, but in our hospital, MRSA infection rate is around 25%. So I believe this is the result of our joint effort. So now we have more and more antibiotics that we can choose from. I believe for us who work in ICU, this is a great news. I believe Professor Chu agreed with me. We hope that we can have less and less resistant strains like MRSA so that we'll be able to have better management. In different regions, MRSA may be very different. And in China, which is a very big country, we actually have a very different rate of MRSA and also CRE. This is another very typical example. In some parts, in Jiangsu and Zhejiang, they may have more than 10%, but for us, we only have like very little cases, only a few cases for CRE. And also, our Italian expert shared with us about the TDM testing, very well managed. This is a patient with diabetes with the skin and soft tissue infection. The reason she had skin soft tissue infection is closely related to her diabetes. We know that for a lot of the gram-negative resistance, previously we don't recommend local regional treatment for these patients with vascular disease. For local concentration, even though for the entire system, the plasma concentration may be good, but the local drug concentration not very good. So for this kind of patients who need debridement, is there any way that we can increase the local regional drug concentration? Because if the plasma concentration is good, but for this patient, the patient actually have poor blood flow, blood circulation. So for this kind of patient without TDM to guide us, is there anything we can do to improve the local regional concentration of drug? This is a question to our Italian expert and also to Professor Wang as well. Is there any better solutions or suggestions that you have?
So if I understand correct the question, in my opinion, it's very important to bring the antibiotics in the place where the infection happened. And in this case, we have, fortunately, we were able to revasculate the leg and to debride the leg, removing the necrotic tissue. So the TDM is important, but we know that we have the concentration in the blood. We have we have to bring the antibiotic also in the skin, in the bone, and everywhere we need to treat infection. But according to the literature, we know the rate of penetration of the most important antibiotics in the bone, in the skin. So knowing the concentration in the blood, we may figure the concentration in the tissue. So for us now, it's very, very important to know the concentration in the blood. So this is my point, my view. Thank you.
Thank you very much, Professor Xing. This is a great question. And also thank you, Professor Tascini. And Professor Liu Shao, please. Thank you very much. I would like to thank Professor Carlo Tascini for your great case sharing, and also thank you, Professor Wang, and also the previous panelists for the excellent discussion. Just now, Professor Tascini shared with us a great case, and also shared with us for patients with diabetic foot infection, how to choose a treatment. I am very interested in the pharmacological related question. For TDM, we have actually talked about TDM quite a lot today. And also for this case, at the very beginning, the patient started with 350 milligrams every other day of daptomycin. And according to the Chinese label for this kind of skin infection, we recommend 4 milligrams per kilogram per day. That's the Chinese recommendation. So my first question is, why at the very beginning you choose to provide daptomycin every other day, 300 milligrams, and later we can see the dose has been adjusted? Is this dose related to the combination with ceftobiprole? And also we can see for the daptomycin, have you considered the adverse reaction? Later we can see that for the daptomycin, the dose being increased to 700 milligrams. And also you use TDM to measure the plasma concentration. And also we can see basically the peak concentration and MIC ratio is satisfactory. Therefore, we successfully controlled the infection for this case. So my second question is, in Italy, under what circumstances do we need the TDM monitoring? Do you routinely perform TDM or selectively for some antibiotics? Thank you very much.
So thank you very much for your question. The first part is why we administer 350 milligrams every other day, because according to our indication for daptomycin reducing dose in renal insufficiency, we may use this dose. This dose was correct. But I believe that I discussed this case because I did not start with so low dose. But we have to keep in mind that septic patients sometimes have a reduced renal clearance for 1 or 2 days due to sepsis. And there are reports in the literature that if we follow the clearance of creatinine and we reduce the antibiotics, the mortality sometimes is increased. So the point is very, very good. And I report this case for this reason. But the second point is that, so when we combine daptomycin with beta-lactam, the MIC of daptomycin is reduced. Unfortunately, we don't know this data bedside. But when we test in vitro for research, or when we are able to do this, we see that there is a reduction of 4 or 8 times of MIC. So also the PK/PD ratio, we don't know the MIC, real MIC in combination. For this reason, when we use lower dose of daptomycin, we combine beta-lactams to reduce the daptomycin MIC and to be in target on PK/PD ratio. So because bedside, unfortunately, we know only the MIC of daptomycin alone and never in combination. And this is why probably is working in the same, the low dose of daptomycin. But also there is the activity of ceftobiprole. So I repeat that there are few hospitals that perform TDM routinely in Italy. For all our patients that we admitted to our ward or with or we consult in the other ward, we routinely apply TDM to moderate to severe cases. For the antibiotics that we are able to measure in this hospital is around 20-25. But for new drugs like, for example, ceftolozane tazobactam or dalbavancin, we are not able to measure. So we send this TDM to another hospital that is more 200 kilometers far. For this case, in these cases, we measure only for more severe and critical patients.
Thank you very much. Thank you, Professor Liu, and thank you, Professor Tascini. We have also learned quite a lot from this round of discussion. I would like to invite Professor Li Yuanyuan. Professor Li Yuanyuan is from Xiangya Hospital, and she's Chief Physician, Doctoral Supervisor, Postdoctoral Collaborator Supervisor at Department of Respiratory and Critical Care Medicine. Thank you, Professor Chu. Today, I have indeed learned quite a lot. I have a question to Professor Tascini.
Sorry, I did not understand the question. May you repeat, please?
The patient is not really responding to the linezolid. Is it because linezolid is not effective for this patient, or is it because of lack of debridement?
So, yes, we did not treat this patient. I understand. Thank you for the question. We did not treat these patients with the linezolid. We did treat with the levofloxacin. But it's true that debridement is very useful, and also linezolid may be used for skin infection. The only thing with linezolid is that we cannot use more than 4 weeks, because the indication is no more than 4 weeks. And linezolid, unfortunately, may have a high rate of adverse event, or neuropathic adverse event. And in patients with diabetes, may be not the good choice if neuropathy is already there. In diabetic foot infection, diabetic foot infection was studied linezolid in a prospective study, but without osteomyelitis, because for osteomyelitis in diabetic foot infection, you have to treat patient for more than 1 month, for 6 weeks. And linezolid you cannot use for 6 weeks in label, because after 4 weeks, adverse event, especially bone marrow toxicity or neuropathy or increased lactic acid is very frequent.
We in Italy are waiting for a contezolid that is less toxic than linezolid. Do you have any experience with contezolid? Because I know that in China is currently on label for skin and skin structure infection. If any one of you has some experience about the use of contezolid.
So for contezolid, actually it is also indicated for the SSTI, but actually we don't have the experiences with this.
Okay, thank you.
Thank you very much. So I think we are done with the first half of the session, and also I think for the MDT has a lot sparkles for our experiences exchange. I mean, for complex SSTI, MASA is a risk factor. We also need to pay attention to that. And also, for example, for patients that have the past medical history of the MASA and abscess, and also the complicated medical history of the antibiotics. I mean, for the Staphylococcus aureus, we do see high prevalence of MASA, be it in China or Italy. And also for the quinolones, it also has high resistance. Therefore, I mean, with the new drugs, we can better save our patients. Okay, thank you very much. Now I'd like to hand over to the moderator of the next session. Professor Li Chunhui. Professor Li is from the Shanghai Hospital. He is Deputy Director of the Infection Control Center, and he has many important academic titles, and is also influential KOL in China. Over to you, Professor Li. Thank you, Professor Chu. Respected chairpersons, it's my great honor to attend today's meeting. So we're gonna have the panel 2 session. So in the second part, we're gonna have 2 wonderful cases. So we're gonna have discussion after the case. So the first case.
我讲一下它的这个英文啊。A case of post operation of infection of aortic dissection 啊。那这是一个。
So this case will be given by Professor Lin Guoqiang. So he is the director of the ICU in the Department of Cardiovascular Surgery. So he's gonna share with us a specific case. I'm also personally involved in this case. Professor Lin is director of the intensive care unit in the Department of Cardiovascular Surgery, Shanghai Hospital. He has many other important academic titles. I will not go into details. In the cardiac surgery ICU, he is very experienced. Over to you, Professor Lin. Thank you. Thank you, Professor Li, for your kind introduction. I'm gonna share my screen. Can you see my screen? We cannot see your screen yet. Okay, we're able to see it. Respected chairperson, respected experts, and Professor Li. My name is Lin Guoqiang. I'm from the cardiac surgery department of the Shanghai Hospital. I think for cardiac surgery department, I'm not an expert in the field of infection. So today I want to share with you a case of the post-aortic dissection surgery infection. Under the guidance of Professor Li, we have very good results, even though the journey of treatment is very rugged. So today I want to share with you the specific treatment processes. So this is a 58-year-old male. The patient came to see us on 10th of July 2024, the patient stayed in the hospital for 81 days. The main complaint is the fever for 7 months after the aortic dissection surgery. And actually, in November 2023, the patient received the surgery for aortic dissection. The patient had replacement of the aorta and with the implantation of the stent, and the patient utilized the multiple antibiotics. And then in the local hospital, the patient had the antibiotic-related complications, and also in multiple sputum cultivation, indicating different kinds of the bacterial infections, such as the Klebsiella pneumonia and Synnectobacter baumannii, etc. And the patient also had the neck abscess in the process. And also, according to the culture, we identified the MASA, and also the patient received the CT, identified the edema in the neck, and the patient utilized all kinds of different antibiotics, such as the meropenem, lalazolide with the cephaloperazone, sulfobactam sodium polymyxin, cephaloxidine, and polymyxin, etc. And actually, the patient has been on the cortisolide for quite a long period of time. So after treatment, the patient had some mitigations of the renal failure and dyspnea. However, the patient still had recurrent fever, and later the patient had the back pain, and then they passed the medical history. You can see here the patient had hypertension, coronary heart disease. The patient had allergic history to penicillin, and the patient had no other abnormalities except for suspicious positivity of the leg elevation test. And so according to the CT workup in May 2024, after implantation of the grafting, actually we see the swelling of the tissue in the mediastinal part. So after the patient is administered to the hospital, and the diagnosis is the graft infection after aortic dissection surgery. And so for the back pain, we suspect that it is caused by the infection or even tumor, and the patient had renal failure, chronic renal failure, and other coronary diseases. And the patient came to our hospital, but the patient is very complicated. So I'm going to give you some infection-related information. So the patient came to see us, and we did the workups, including the blood routine test. The patient had an anemia, and the patient had repeated fever. We also checked the immune system for this patient. There's no special abnormalities where was of tension, and I can see C protein and procalcitonin were abnormal, and with the sputum cultivation, we had MASA identification and Pseudomonas aeruginosa. For MASA, it is persistent throughout all the workups for blood culture. We also identified MASA. And so when he was administered to our hospital, we did the lumbar MRI, so indicating the osteo or the bone marrow edema in L4, L5. And so back then with the MDT discussion, we were highly suspicious of infection for this patient. Therefore, according to the ESVS guideline, and so when we have the persistent fever and inflammation after aortic graft implantation, we need to identify the infection source. So the patient had the abscess in the incision site and also had abscess in the neck. So we were suspicious of the graft infection for this patient according to the guideline. So we need to do the CT. And so in May, we did the CT, and according to the guideline, we can further perfect the workup with the PET CT. So then we did the PET CT for this patient. So after the PET CT is done, then we're able to confirm that the patient had the glucose intake elevation in the paragraft and stent areas. So according to the classification of the MAGIC, so we can see the patient had at least 13 necessary conditions, and the cultivation is positive, and we also see positive imaging signs. And for other secondary conditions, for example, for PET-CT, and we also see those positive signs. And the patient also had some clinical manifestations such as the wound exudates as well as the abscesses. Therefore, according to MAGIC guideline, so we are able to establish the aortic graft infection diagnosis. So for aortic graft infection, among all the guidelines, conservative treatment was not recommended. The recommendation is to do thorough debridement and also to remove the graft and also to do the vascular reconstruction. So even though guideline didn't recommend conservative treatment, however, according to our experts, we had a consensus that for the aortic graft infection, so all the conservative measures will not be recommended. The only way out is to do thorough debridement and remove the graft, and then to do the revascularization or the vascular reconstruction. So once we confirm the diagnosis and we did the broad MDT, and then the surgeon thought that the stent and the graft was not able to be removed by the surgery because the patient was in very poor situation. Surgeons don't dare to do surgery for this patient, so they suggest to do the conservative treatment to control the infection. And also for family members, they're also scared of the surgery, so we can only utilize conservative treatment for this patient. Therefore, the diagnosis is confirmed for the metastatic abscesses with the infection of the graft, and also the patient had abscess in the neck for the treatment for the antibiotics because the patient was on the almoxicillin as well as the cortisone the last time he was discharged, so we continue on this antibiotics. And actually, after the utilization of those biotics, the blood workup result improved. So after the MDT discussion, we made a decision to continue to utilize the with cortisone for this patient. And then we switched the cycling oral drug for this patient. We also communicate with the patient relatives, telling them about the information. So without surgery, the patient has to be on antibiotics for quite a long period of time or even throughout his life. So these are the general information. And in this process, we understand the reality is very harsh with the combination of the amodicycline and cortisone for 1 month. The patient began to have PCT, low fever, and C protein elevation.
Here we can see the patient's CRP still in very high position, and PCT is still high. The patient still have lower back pain, and the lower back pain is so severe at night. The patient actually tried to commit suicide. So the pain is very severe for this patient. We have done the sputum culturing for this patient, and still Pseudomonas aeruginosa and MRSA, and blood cultures show MRSA. We have also performed the MRI for the lumbar vertebra, and actually the MRI suggests the infection progressed. So for us, for the infection management, we don't have much treatment options available. And in terms of the antibiotics use, we don't have a lot of antibiotics that we use. So for such a complicated case, we've managed this patient together with Professor Li. So for such a complicated case, in terms of the antibiotics selection, we have a lot of impacts. For example, for this patient, the patient family member is quite sensitive about the signs and symptoms and also the renal function. So if there's some treatment that might affect the kidney function, the patient family member will refuse to take that. And also the patient is very familiar with the side effects of antibiotics. So if we talk to them about the antibiotics use, they always respond with a lot of questions. And this is a patient with MRSA and also very clear infection of the aortic vascular graft. So for the antibiotics, we need to select. It will have to be an antibiotics that manage to treat the Staphylococcus aureus bacteremia and also can inhibit the biofilm of Staphylococcus. So this antibiotics will have to be able to inhibit the synthesis of the Staphylococcus biofilm. The patient also has the bone tissue and also soft tissue, skin tissue involvement, and also have this abscess in the neck. So for the antibiotics that we need to select, it will have to be an antibiotics that can also treat the skin and soft tissue, bone and lung infection, because we can see for the patient's sputum culture also showed MRSA, and the patient family member would like to preserve the liver and kidney function. They hope that the antibiotics we choose should not impact the liver or kidney function. And also the patient have actually used linezolid before, and after linezolid treatment, the patient actually had significant platelet count reduction and have the airway bleeding, almost suffocate because of that. So we decided to choose something with no obvious bone marrow suppression and can act as a rapid bactericide. So basically, I think our treatment option is related to all of these above mentioned factors. So for us, eventually we have selected the treatment, which is ceftobiprole. And for ceftobiprole, basically in China, the approved indication is only hospital-acquired pneumonia or community-acquired pneumonia. So for us, we actually refer to the US label of ceftobiprole. And in the US label for ceftobiprole, it seems that it can treat the S. aureus and also has the indication to treat the lung infection, etc. as well. Therefore, according to the hospital policy, we decided to treat this patient with ceftobiprole in an off-label way. We have communicated thoroughly with the patient and family member. We have also communicated quite thoroughly with the patient and the family member about the efficacy of using ceftobiprole in treating the S. aureus bacteremia. And also there's no relapse and resistance. So we have communicated all of this information to the patient. And for the aortic vascular graft infection, basically for this kind of infection, S. aureus is the most common strain. And also we have already confirmed that this vascular graft infection is because of MASA, MRSA. So for ceftobiprole, if it can inhibit the biofilm, then it would be the best. We have done some literature search, and we can see that for ceftobiprole, it can indeed inhibit the biofilm. We previously wanted to use vancomycin, but the patient family member decided not to use vancomycin and because of the kidney function. And for rifamycin, daptomycin for S. aureus, basically they are not as good as the ceftobiprole. And also we have data suggest basically with the same clinical therapeutic concentration, ceftobiprole has very good inhibition effect for MSSA and MRSA biofilm formation. Therefore, ceftobiprole has been recommended to be the first-line treatment option for primary MRSA BSI. So we have communicated with the patient and family member, and on 7th of August of 2024, we have discontinued the omecicline and cortisolate and started to use, started to use the ceftobiprole and cortisolate combination. So back then we have basically no understanding about this new drug. So we did very thorough monitoring about the side effect of ceftobiprole. So after 3 days of ceftobiprole, we can see the symptom has been greatly relieved and WBC start to reduce and the back pain start to alleviate, start to improve. And the patient said that the patient feel much better than before. And also for blood routine, liver and kidney function, basically we measure blood routine, liver, kidney function every 2 days. After 2 weeks of treatment, we have done the blood culturing and it's negative. And on 19th of September of 2024, the patient has received 42 days of ceftobiprole because according to the US label for as aureus BSI, we should use 42 days of ceftobiprole. So we have used a full 42 days for ceftobiprole for as aureus BSI. And on 19th of September, we did blood culture and it's negative. And the patient never had MASA, never had MRSA. And later, when we recheck the blood culture, it's still negative. During the entire monitoring process, the patient's blood routine, platelet count, etc., all of them are normal. And we did not see any platelet count reduction, no bone marrow suppression. And the kidney function, actually CKD switched or improved from phase 5 to phase or stage 5 to stage 2. So the patient is now being prepared for discharge. We actually want to extend the use of ceftobiprole, but for ceftobiprole, we have no experience. And also, according to the label, the maximum duration is 42 days. So we don't know whether there's new side effects, etc. So we have to discontinue ceftobiprole. And we switch to omecicline and cortisolate oral treatment, and the patient has much improved. And also the patient had abscess in the lumbar vertebra, and the antibiotics for that abscess need to be used for 3 months. So the patient been discharged and also still receiving oral omecicline and cortisolate. Later, the patient blood tests are all normal. So we have done 2 times of blood culture. We can see this is the blood culture result on 23rd of August, and this one is the blood culture result on 18th of September, and they're all negative. So the patient came back to the local hospital, being discharged from our hospital, and go back to local hospital for further checkup. We can see the CRP of this patient is back to normal, and also PCT is normal as well. So for this patient, this actually has never happened. CRP and PCT normal has never been the case, basically, for this patient, even though for this patient previously, the PCT and CRP been reduced almost to the normal level. However, the patient never had normal PCT and CRP, so the patient is very happy. We can see the liver function and also kidney function are all very good. At the very beginning, when the patient first present to us, the creatinine is around 500. So now we can see the creatinine clearance is basically 50 in later checkup. So the patient and patient family member are very happy with the treatment efficacy. These are the feedback from patient, and the patient is now under great recovery. Until today, the patient actually came back for follow-up today. From the evidence we had so far, from the information we had so far, we can see the patient has been doing great, and the abscess in the mediastinum has already been absorbed. So for this kind of vascular graft and endograft infection in cardiology surgery, we have only less than 1% of VGEI incidence. However, if there's aortic vascular graft infection, the mortality rate can be very high. Here we can see from the guideline, it's around 58% for aortic vascular graft infection, especially if it's in the chest aorta, the mortality rate can be very high. And also for the most commonly seen pathogen, we have seen most commonly for gram-positive, it's S. aureus. So we can see from the patient blood culture result, the patient had MRSA. From study result, we can see S. aureus and also E. coli, Pseudomonas aeruginosa. These bacteria are more virulent. And also if we do the in situ vascular revascularization, then the patient are more likely to have relapse of infection. However, for patients with aortic, chest aorta issue, we'll have to do the in situ vascular revascularization. So for this patient, the patient is having a lot of risk. So for VGEI, anti-infection is very important. And of course, our anti-infection treatment is guided by this susceptibility test. And also for this patient, the treatment course of antibiotics for patients who cannot tolerate surgery, they will have to receive antibiotics indefinitely. From the guideline, we can see basically from the existing guideline regarding to VGEI, the guideline doesn't really recommend conservative treatment. Conservative treatment in the guideline is only recommended to patients who cannot tolerate surgery. We can see for VGEI happened in thoracic aorta, the mortality rate is very high because for thoracic aorta, you have to have in situ revascularization. Unless for example, abdominal aortic problems, we can probably have some of the non-in situ revascularization to avoid further relapse. However, for aortic arch, thoracic aorta, that's not the case. So we have talked about the complete debridement and also the revascularization, etc. Actually, the debridement surgery is very complicated, very difficult to perform. Here we can see this is a video of the surgery. Here we can see we just put it in and we try to remove that. And as you can see how difficult it is. And for the ones that are, this is how complicated it is when you're trying to remove that immediately. And if there's infection, as we can see on the right-hand side, there's a lot of necrotizing tissue, a lot of infected tissue. So as you can see here, for these kind of infected vascular graft, and also if you want to remove that and then do a reconstruction or revascularization, again, with a vessel graft in the same place, we do have very high relapse rate. So what we do need is very good antibiotics so that we can reduce the future relapse incidence.
So this surgery is actually quite complicated. So the incision is even more than 1 meter. And for this aorta, we need to reconstruct it to this part on the left. You can see this schematic picture. This is not an infectious patient. And so from the abdominal aorta to thoracic aorta, we did this reconstruction. And so you can see all those organs and diaphragms in this picture. And you can see the wound is very, very big. And so for those patients, they are more likely to have infection. So you can easily see from this picture. So for thoracic aorta, for this part, actually, we cannot do the engraftment or transplantation. And so for the in situ reconstruction in the infection lesion, sometimes they would have high probability of the relapse of the infection. And that's why for those patients, they have high mortality rate. And so do we have antibiotics to treat those patients in a conservative way? We sincerely hope we have the antibiotics to have the conservative treatment. And also, I hope that I can have the antibiotics to reduce the reinfection risk. Actually, in 2023, we see there is a study published by the VSC for patients that are contraindicated for surgery. There's a single center retrospective study without removal aorta graft with targeted antibiotics. It may work for the VGEI for aorta, and it is not always necessary to have patients on lifelong antibiotics, even though the likelihood is minimal, but as long as we're able to choose the right antibiotics and the right treatments, it may work. So that's all from me. Thank you very much. Thank you. Thank you, Professor Lin, for your wonderful case. This case is very complicated, and the total treatment duration is almost 1 year. And I personally involved in the whole anti-infection treatment for this patient. So I think for the successful treatment of this patient, I also feel very excited. Thank you, Professor Lin, for your kind presentation. So next, we're gonna have the discussion. So
yes, thank you very much. Okay, thank you very much for your clinical case. I would like to ask if you believe that ceftobiprole has antibiofilm activity alone or in combination, and if you use for this reason or for other reason. Thank you very much.
okay. Thank you. Thank you very much for your question. Actually, for the ceftobiprole, it is the first time for me to utilize it. Before that, I didn't have the experience for it. And actually, the patient utilized the cortisolite. It worked for this patient. So that's why in the very beginning, we tried conservative treatment because we were not sure about the ceftobiprole. So we also communicate with the family members. So we can add on the ceftobiprole to control the symptom, and we will have close follow-up to see whether if it works. So we didn't think about monotherapy for the ceftobiprole, so we try to be more safe for this patient.
Okay, thank you.
Thank you so much for your presentation. It was really amazing. I would like to ask you, if I understand well, this patient is under long life suppressive antibiotic therapy. Is it correct? Okay. In this case, how long do you think you think that the suppressive therapy should be continued long life, or you think that an imaging-based approach, such as using of serial PET-TC, F18 PET-TC, can be used in order to withdrawal at some point in the history of the patient the suppressive therapy? Do you think that you can use imaging in order to withdraw at some point in the history of the patient the suppressive therapy?
Thank you for your question. So I think for this patient, according to the European guidelines as well as the China expert consensus for aortic graft infection antibiotics treatment duration, we do have the clear statement. So for conservative treatment patients without removing graft, they suggest the long-term or even lifetime antibiotics treatment. Actually, cortisolite for the first time has been utilized by us for this patient. We also communicated with the family members. So for this disease, if we don't do surgery, you need to take antibiotics for a very long period of time or even throughout their lifetime. Of course, you're going to have some side effects, and sometimes you may even stop the drug because of the severe side effects in terms of their surveillance for the bone marrow suppression and the renal kidney function. We need to do the routine follow-ups. So right now, every 2 weeks, the patient will go to the local hospital to do the routine follow-up workup and then send information to me. So right now, the patient came back to see me for follow-up workup. I did the lumbar MRI. We also did the blood test. So currently speaking, it works very well for this patient. And the patient actually was on the aminocycline and cortisolide, and the patient has thrombocytopenia. And so when the platelet count reduced to 90,000, we stopped the aminocycline for 2 weeks. Then the platelet didn't decrease further. That's why we still suggest patient to utilize cortisolide. Or when can we stop the antibiotics? Just like you mentioned, we can refer to imaging studies and also combine imaging studies with the mitigation of the lesions as well as the blood culture. And if we're able to have the NGS negativity, if it is negative, and we would be careful, very careful with the decision as whether to stop the medication or not, because it's quite difficult to make the decision, because according to guideline, the patient has to be on antibiotics throughout the whole lifetime. So I want to add on some extra information. I also want to give you some extra information because the patient had lung massa and then we identified massa in the blood. So we were suspicious that this has been disseminated from the lung to the lumbar and also maybe even to the graft vessel. So now we did the analysis, we had this suspicion. And so we did PET-CT for this patient to confirm the diagnosis of the infection on the graft. And so according to the metabolism signal of the PET-CT, it indicated infection because we were not able to tell the infection from the MRI, but we were able to tell it from the PET-CT. So we can utilize images and also the infection, the graft infection at this time window. The conservative treatment worked, maybe because it is disseminated from other locations. If it is primary infection, it's going to be more difficult to treat. So this is another scenario that I want to underscore. So currently speaking, the treatment duration is way much better than what we have expected. So I think this is my personal guess. Okay, next, I will hand over to Professor Li Yuanyuan. I will not go into the detailed introduction of Professor Li again, because we already introduced her. So I want to thank the speaker for the wonderful case. This is also successfully treated case the patient is still on antibiotics. And actually, for this patient, we don't have 100% surety for the final success. So with this opportunity, I have two questions for the Italian professors. So, and just now, Professor Tascini shared with us in his talk for the datomycin in combination with the ceftobiprole work very well for MASA. So for this patient, if we have relapse of the bacteremia, maybe we can try the datomycin with the cefalobiprole. The second question is for cefalobiprole. How long is the duration that is safe without any side effects? Professor Tascini and Professor Simon.
Actually, for example, we have used ceftobiprole in a patient with Enterococcus fecalis endocarditis for 6 weeks, and we have not found any toxicity. But I have to underscore and I have to stress and highlight that we use TDM for all the treatment course. So maybe by optimizing therapy and dosages with TDM, it is possible not to reach this condition in which the patient does not experience any toxicity. In my personal experience, our experience is that the use of ceftobiprole up to 6 weeks is not toxic for a patient, if TDM guided, of course.
So if I may add something, I would like to say that I agree with Simone. We have the same adverse event of other cephalosporins, and 6 weeks is we use for endocarditis this long time of treatment with ceftobiprole, and using TDM we have few adverse events.
In our personal experience of 21 enterococcal endocarditis, we experienced just 10% toxicity rate and 10% toxicity rate at just one seizure. So it is not very high, almost the same as the other cephalosporins.
Okay, next, I'd like to give the floor to Professor Su Yuan. She's from the Qingdao University Affiliate Hospital. Thank you very much for your kind introduction. I also want to thank the speaker for the wonderful case. Actually, for the hospital-acquired MASA-induced severe infection, actually in ICU it is quite rare. And Professor Chen also shared with us the experience as we continue to step up the infection control. The severe hospital-acquired MASA is rare, and we treated C-MASA-induced necrotic pneumonia patients. For those patients, we would establish a MDT. I also echo with Professor Lin, saying that actually we can have combined teamwork.
For severe infection, firstly, we need to have drainage of the infection site. So basically, by doing that, we can reduce the mycobacterial load. So, and also for antibiotics, according to the labeling dose, basically, we need to consider whether we are dealing with, for example, if it's bacteria number 10 to the number of 5 or 10 to the number of 10, it will be very different. So drainage is very important as well. For this patient with lumbar abscess, I don't know whether from imaging, whether you have done drainage for this lumbar vertebra abscess. And have you done the evaluation? Why didn't you do the drainage? And today we have talked about very good new treatment for MRSA management. We haven't had the opportunity of using sector bipro in our hospital. I hope in the future we'll be able to have opportunity of using that myself. Professor Su, about your question of drainage, we actually had the spinal surgery and also ultrasound doctor for consult, but they believe this is a patient not suitable or not indicative for surgery or biopsy. The abscess, lumbar vertebral abscess, is very small. It's actually a very small one. And also the patient had abscess in the neck and later mediastinal infection. Yes, it's actually maybe the mediastinal infection spread to the neck. For the neck abscess, we have done the drainage. And for neck abscess, we have drained for 2 weeks. And the patient came back to hospital for a checkup today, and the patient is completely fine. So I believe for this kind of case with mediastinal inflammation, for this kind of patient, they usually will be also affected by gravity. And for this kind of patients with mediastinal infection, we will put a drainage tube in the mediastinum for fenestration, and basically we will do the drainage there and to have better control. I think for mediastinal infection, this is more common in cardiology surgery department. For mediastinal infection, previously the mortality was 100%. But now for mediastinal infection, for patients who already had open surgery, we will use the vacuum drainage to drain. Otherwise, the mortality is really high. So by doing that, we'll be able to significantly reduce the mortality, like Professor Su mentioned. Actually, but for us, basically managing infection is to cut it open and to drain. I think what you have suggested is very well in line with our infection management principle. Thank you, Professor Su. And the next one is Professor Deng Sheng from Xiangya Hospital, who is Chief Pharmacist at Xiangya Hospital, affiliated to Central South University. Professor Deng, please. Thank you very much for the introduction. And also thank you, Professor Lin, for this great case you have shared. Indeed, in our clinical practice as pharmacists, we have also participated in the antibiotic stewardship. We focus more on gram-negatives because in general, for gram-positive, including MRSA, we have some very classical treatment and they are working really well. The resistance rate not very high from our hospital monitoring and also from the overall situation seems to be very good. About the vascular graft infection, because as pharmacists, we're also involved in this kind of aortic graft infection management. You have also mentioned about the cortisone and omacycline and later ceftobiprole was very good efficacy. So for disease management, of course, we want to manage our patient in safe and cost-effective way. Like you've mentioned in your presentation, if we consider lifelong treatment in terms of compliance of our patients, I think as pharmacists, what we hope is after patient being discharged, we probably can choose a dosage form that is more convenient, for example, oral treatment, because the patient will have to receive very long-term treatment, maybe indefinite treatment. So we probably will use something safe, because no matter what treatment you use, if you use them for a long run, basically there are going to be some impact on kidney and liver function. And then about affordability, like you've mentioned before, we have to consider lifelong treatment for patients. the affordability is an issue. For gram-positive MRSA, for example, we have had some treatments available, and most of them are IV treatment. We have very little oral treatment. And also for new drugs, oral new drugs are very expensive. So from your perspective, and also from your experience, for long-term treatment and also for patient preference, for gram-positive treatment, long-term treatment of gram-positive in terms of affordability and safety, which treatments do you prefer? Which treatment do you think that are suitable for lifelong treatment? Thank you, Professor Deng. We actually talked to you quite a lot about cortisone use for this case. I try to answer this question, and maybe Professor Li can add. Because for this patient, it is possible the patient will be on lifetime treatment. We do have some oral treatment available, for example, rifampin, etc. We have actually considered about this, and also linezolid. For linezolid, for this case, the patient received linezolid in local hospital and in our hospital. However, after linezolid, the patient suffered from very severe thrombocytopenia and actually had one very severe respiratory tract bleeding, almost suffocated due to this bleeding. So for linezolid, of course, we will be very vigilant. When we first saw there is a neck abscess, we decided to try linezolid, but the patient family member strongly refused to use linezolid because even though for patients who use linezolid, the patients still have thrombocytopenia, etc. Later, Professor Li said that we actually have another treatment, which is cortisone. We can try cortisone as well. So the patient is now on the oral treatment for 3-4 months. We've been monitoring this patient. The patient's liver function and kidney function, so far, it seems the liver function and kidney function not being impacted by the oral treatment. And the patient being discharged on September 20th, and in October 13th, we do see platelet count reduction. So we have decided to discontinue omacycline, and the patient still on cortisone. After omacycline being discontinued for a week, we can see the platelet count stop reduce and start to recover. So we can see for cortisone, for bone marrow and liver and kidney function, cortisone had little impact on that. And for cortisone, it's indeed very expensive. The patient and family member, they have very good affordability. So for this case, they don't worry about the price, the cost. But of course, for cortisone, if we use that long for a very long time, eventually, with prolonged use of cortisone, the accumulation effect may be something we have to consider. So we are still monitoring this patient closely. We are also in search of a replacement for cortisone as well. We have tried rifampin. However, basically, for rifampin will not work for the S. aureus biofilm. So we were quite also like hesitated, or we are still in the search for better treatment. Maybe Professor Li or others can have some suggestion. The patient organ function is quite sensitive. The kidney function, as we can see, when the patient first present to us, the patient had acute kidney injury or acute kidney damage. So the patient actually required dialysis, and later the kidney function recovered. And also early on, the patient tried linezolid, and very early on, the patient was fine on linezolid, but later the patient started to have adverse events with linezolid. So the patient had very sensitive organ function. So for this patient after discharge, the patient will receive oral cortisolid and omacycline. So for this case, we also need to consider whether the patient can use omacycline and cortisolid for the long run. We still have to closely monitor this patient and see how the patient is doing. But so far, the patient is doing well. Thank you. Thank you, Professor Lee. I have something to talk about for this case. Please go ahead, Professor Wang. We had great discussion tonight. Sorry that we have already run over time. And for me personally, I do have some clinical experience I would like to share with you. For me, I probably will use daptomycin and ceftobiprole because they both are bactericides and they are very good partner. If you use daptomycin alone for patients who have valve replacement, aortic arch stenting, etc. For MRSA infection, basically, if you use 6 weeks of daptomycin, 42 weeks, then 2/3 of the patient can be fully recovered. They can discontinue daptomycin after 6 weeks without relapse. So we do have this experience. So daptomycin, it's very good at clearing the biofilm. So it's a very strong bactericide. So from Professor Lin's case, from the presentation, for biofilm inhibition, you can see you have compared different drugs in terms of the biofilm inhibition. We can see for ceftobiprole, it's even better than daptomycin in terms of biofilm inhibition. If it's really that good, then ceftobiprole and cortisolid for 6 weeks. After 6 weeks, we can try discontinue because I don't think indefinite treatment, lifelong treatment is a good option because later you will see other issues like fungal infection, and also the price is another issue. Even though the patient had relapse, you can still restart the treatment and it will still work. So for this patient, I think there is a possibility that after discontinuation, like I have suggested, we can probably solve the case. About linezolid and cortisolid. Linezolid and cortisolid, they are basically inhibiting the bacteria. For bloodstream infection and endocarditis, we usually don't use that, including omacycline. Linezolid, cortisolid works very well for enterococcus. Basically, if it's enterococcus, it's much better than daptomycin and vancomycin. And also it's an oral therapy because for enterococcus infection, basically, I think that's a very good treatment option. And also for omacycline, for tetracyclines, the blood concentration is very low, and also it's a bacteria inhibitor. I don't think it's a very good option. So we have very little evidence. And for rifampin should not be used longer than 2 weeks. If it's more than 2 weeks, you will have 100% of resistance.
So that's the positive bacteria. I also encounter a lot of gram-negative cases, such as the aneurysm stenting patient. So they have a lot of gram-negative infection. And for the gram-negative patients, it's gonna be more difficult. And also, sometimes the strains will become resistant. They're gonna become like the glycolysis resistant patients. And for candida, and we will see even fungi infections, so it's gonna be more tricky. So I mean, for those patients, if you continue to step up, there's gonna be like a vicious cycle. And for fungi induced artificial valve infection, those patients have to be antibiotics throughout the lifetime. But for the rest of those patients, it's difficult to have them on the lifetime treatments. And except for the side effects, we're gonna see the infection of other bacteria. And also for gram-positive infection patients, maybe treatment can be easier. So that's my personal opinion. Thank you, Professor Wang, for your kind experience sharing. Because currently speaking, the treatment is very successful for this patient. And for the follow-up treatment, we can also follow the guidance from Professor Wang. Right now, we only utilize the cortisoid as the monotherapy. Sorry. I have a question for Professor Wang. So for this patient, can we try stop the medication? Yes, you can try that, because if you continue to do this, there's no end for it. Because I think for gram-positive infection patients, evidence is not that strong. I mean, for some other drugs, and when they use those drugs, they can be cured or they can replace the valve. Well, we place the stent and replace part of the aorta with a graft, with the endograft. So I understand it's quite tricky. So I think for this patient, I think we lost Professor Li. So in general, so for endograft, we can also utilize MRI to check whether there is low density lesion in the neighboring part of the vessel. And so if there's no low density lesion, I think the treatment goes well. So today, the follow-up CT and also for the thoracic CT, there's no low density signal. However, for the lumbar lesion, the lesion has not been totally absorbed. So that's why I don't dare to stop the medication, because the abscess in the lumbar part has not been fully absorbed. Yeah, I understand it's quite tricky. So I think for the lumbar vertebra, and maybe we can also utilize almocycline, and many of my patients can utilize almocycline and doxycycline for 2 months. So they work like the cement for those patients for the lumbar. And I think for cortisoid concentration is also very high. I think it's able to control the infection. Just the patient needs time to regrow the bone. Okay, thank you. Thank you all very much. So we had a very detailed discussion of this case, and Professor Wang also gave us a very wonderful discussion. And so I understand we're way behind the schedule, but we still have another case. So this case is a severe pneumonia case. The speaker is Professor Song. So Professor Song is from the affiliate hospital, Qingdao University. So today she's gonna give us this case. Okay. Thank you, Professor Li, for your kind introduction. Can you see my slides? Okay. Are you able to see it now? Yes. Respected chairperson, distinguished experts, dear colleagues, good evening. It's my great honor to attend this meeting and also to have the exchanges with the top international and domestic KOLs. Today, I want to share with the diagnosis and treatment of severe pneumonia. So this is the general information of this patient. Male, 14 years old. The patient was admitted due to fever for 5 days, cough with chest distress and suffocation for 4 days on December 14th, 2021. And 5 days before the admission to the hospital, the patient had a fever. The patient didn't have symptoms, but later the patient had a cough. The patient has been on the anticold drugs. And then on the 22nd, the patient did the blood check, and actually the neutrophil is 88% and lymphocyte ratio is 92%. The patient was on clindamycin. And so 1 day ago, the patient had the worsening of the symptom, and the patient has been confirmed with the lung infection, and the patient was administered to our hospital, and we see the neutropenia and CRP and the PCT was elevated. We're not able to see your slides. Sorry about that. Can you see my slides now? We're not able to see your slides. We're able to see it. Yes. Sorry about that. So I will continue with my talk. So this is the medical history. So actually, on 13th December, the patient was administered to the ICU in the hospital. And so the patient had reduced the neutrophil and white cells. And the patient actually had a shock. And the patient had a pulmonary failure. And also the patient was on ventilation. And also the patient was on meropenem, vancomycin, azithromycin, and oseltamivir. So under this treatment, the patient continued to have the worsening of the oxygenation and with the pulmonary CT. 1 day later, the patient had progression. And so the patient was administered to our hospital because of the severe pneumonia. The patient had a fever, and the patient had a low hypotension, shock, as well as the respiratory failure, and the patient had a ventilation and endotracheal intubation. The patient had coarse breath sounds in bilateral, wet rounds was also heard in bilateral. For auxiliary examinations, according to blood gas analysis, pH 7.29, and according to blood routine, with the reduction of the WBC, the platelet, the hemoglobin, and CRP, PCT were elevated, and also blood coagulation routine indicated the PT elevation of PT-ABTT and fiber and cardiac enzyme was also elevated, and the patient had the NKI, and also the patient had the hypoalbuminuria, and the patient had the mycoplasma IgM, and the sputum cultivation also indicate gram negative infection. According to the ECG, we can see the bradycardia. And so the patient received the pulmonary CT indicating multiple patches. And this is the CT 1 day later. The patient had the progression. And so we say all those worsening symptoms, the diagnosis was severe community-acquired pneumonia with infection of the staphylococcal pneumonia, ARDS, septic shock, multiple organ failures, thrombocytopenia, acute kidney injury, and also suspected case fatality rate is 53.3%. And of course, the initial treatment would be active search for infection site, initial and period infection, as well as the respiratory support. And we gave the meropenem, lenazolone, the azithromycin, and stamivir for the treatment. And also we did the mechanical ventilation with the recruitment in terms of the circulation. The patient had the shock, and also we utilized the hemodynamic monitoring, noradrenaline, and wound loading test. And also, in addition to that, we also try to elevate the WBC, promote platelet production for this patient, etc. And so we can see the final test result indicates the MARSA and the vancomycin and niacinamide was also sensitive. And actually, according to the management process, and we did the deep sedation with muscle relaxation. And according to the images, we can see the patient also had some severe symptoms. And so after pulmonary resuscitation and the oxygenation increased to 130. However, on 16th December, the patient continued to worsen. And also for blood gas oxidation was increased to 100 and saturation was reduced to 61%. With the pulmonary resuscitation didn't work out. The blood gas indicates the retention of carbon dioxide and pH was 7.12 and oxygenation index was 61%. With the pure CT chest X-ray, and we see huge progression for this patient, and excluding contraindication, we consider VV-ECMO. So this is the recommendation of the VV-ECMO for children, and for the severe retention of carbon dioxide, we can exclude the contraindications, then we can utilize this. The patient was actually indicated RASP score was 4, and for the ECMO, survival rate is 76% as we expected. Then we utilized the VV-ECMO for this patient, and then we reduced the ECMO parameter, and we utilized the ultraprotection pulmonary ventilation for this patient. Up to now, we can see that in clinical practices and in the images, the patient actually progressing. How about the infection for PCP was decreasing, and because of the dialysis, actually the body temperature was not able to reflect the true situation. CRP was still elevating. So at this time, we also did the pathogen test. Actually, we can see the pneumonia, the positive, staphylococcus aureus positive, and MARSA positive. So these are also the related tests. For the rest, they were negative, and for the IO6, it was more than 7,000. It was indeed very high. And also, after the patient was administered at hospital, the test report was also MARSA.
We can see that linezolid MIC is 2, vancomycin MIC less than 0.5. Patient's platelet is reducing, so we had a MDT consult, and it's recommended according to our hospital consultation to continue meropenem, discontinue linezolid, and switch to vancomycin and have TDM, because basically for us, we have also switched to moxifloxacin because of resistance to azithromycin, and also did a NGS sequencing. This is the NGS result. We can see from the sputum NGS, it's Staphylococcus aureus sequence number very high, more than 410,000. And also here we can see that for the blood MNGS, the sequence number is 615. This is the circulatory support. According to the research bundle, we have had the broad spectrum antibiotics, obtained etiological culture, fluid resuscitation, etc. And we can see the patients have tend to stabilize the circulation, or adrenaline is reduced and lactate is progressively reduced. And here we can see the patient had a very significant pneumothorax. And also we can see for this patient, when we know about the infection of MRSA, we know there's a very high risk of pneumothorax. So we have communicated with the patient family member, and also we have signed the informed consent about the drainage. Here we can see that comparing to before the drainage and after drainage, we'll be able to see some of the recruitment of the lung. And this is our anti-infective treatment strategy as being listed here. And here we can see that on the 23rd of December, we can see the CRP and also other infection parameters tend to increase. So we have rechecked the chest CT. We can see from chest CT very severe cases. We had another MDT for this patient, considering this is a patient with MRSA in lung and also in the bloodstream, very virulent. So we decided to use vancomycin, linezolid to treat MRSA. And also we have started to use the TNM and also oseltamivir and also moxifloxacin. So we can see on the 24th of December, the fungal test suggests D-glucan 1218, and also the sputum smear suggests yeast-like fungal spores and pseudohypha. And we had another specialist consultation. They also recommend vancomycin, linezolid, imipenem, cilastatin, and caspofungin combination treatment, and also suggest to use fiber optic bronchoscopy and also prone ventilation, as well as tracheotomy, and also to taper the steroids, as well as to have bedside minimally invasive tracheotomy. So we have communicated with the family member about the possible poor prognosis, and on the 24th of December, we did a bedside minimally invasive tracheotomy, and we can see that on 27th of December, we do see purple-black coloration of the first interphalangeal joint of the red index finger and beyond. And considering the patient had MRSA bacteremia, and we decided for this patient we should use ultrasound to check the heart. And since we only perform the bedside ultrasound, we cannot completely rule out the possibility of infectious endocarditis. And the MNGS suggests the MRSA sequence still very high. And we have invited pharmacists to join the consultation, and they recommend to stop vancomycin, change to daptomycin to treat Limasa, the MRSA. After adjustment, we can see this is the infection parameter change. We can see after changing to daptomycin, there is a reducing trend of CRP and PCT, etc. And also the lung compliance improved, blood gas analysis becoming more ideal. So we start to try weaning of VV ECMO. On 31st of December, the patient passed the ECMO weaning experiment. We successfully weaned the VV ECMO. This is the first CT after weaning of the ECMO. We can see, comparing to before, there are some improvements, still some pneumothorax, and also some of the effusion. pleural effusion, and if effusion culture is negative, and here we can see basically we do have a like a cavity or a hole quite close to the pleural, so the patient still have some risk of pneumothorax. And on the 7th of January, the patient stopped CRRT and had the femoral venous catheter withdrawn. And on 9th of January, the patient is on daptomycin, linezolid, and piperacillin, tazobactam, and remove the chest drainage tube on 11th of January. And also the patient had sealing of gas cutting canal on 10th of February and replacement of the metal sleeves on the 6th of February. About anticoagulation management, we have also done some evaluation and adjusted the anticoagulation target. We've monitored the thrombosis, bleeding, and hemolysis. So while the patient is on ECMO, there is no bleeding or thrombosis formation. However, after ECMO being removed, we can see basically we have seen the right internal carotid thrombus and also the hypoechoic right basilic suspected thrombus. So the patient actually had the blood sputum, so we have intermittently withhold the anticoagulation. The patient had MRSA, bacteremia, so we decided to choose the conservative anticoagulation treatment and monitor the thrombosis. And we can see during monitoring, the thrombosis all disappeared. This is actually one of the reasons why the patient been hospitalized for a very long time. About sedation and analgesia, the patient is on ECMO, etc. So for this patient, sedative and analgesia are very important. We start with deep sedation, analgesia, muscle relaxation, slowly progress to shallow sedation and awake. So the patient is only 14 years old. So the delirium is very important. We need to prevent delirium. So we use the radio tape recorder, letter, photo, and other means to accompany the patient and also encourage the patients to boost the confidence. We also try to make sure we have circadian rhythm being maintained and also use some of the drugs to improve sleep structure. Here we can see the chest CT show improvement. About outcome, this is a 14-year-old boy from despair to hope. The patient has recovered and been discharged. So this is a CA MASA case. So I would like to share about HA MASA being first identified back in 1970s, and it spread between personnel in contact with healthcare facilities. CA MASA being first discovered in 1990s, and CDC in the United States reported that CA MASA resulted in 4 mortality death in a short time, and that's the first time we identified the CA MASA. So basically, we can see that MASA strains isolated from patients in outpatient clinic or within 48 hours of administration. This is a criteria. And CA MASA, HA MASA are different according to the characteristics of them. We can differentiate them. For CA MASA, these are patients who are students, athletes, military personnel, prisoners, and also are more likely to have skin, soft tissue, and infection manifest as a cellulitis, etc. However, for HA MASA, usually elderly, debilitated, chronically ill, or chronically ill patients. And for CA MASA, most of them carrying PVL gene. And also the FCC-MAC type 4 and type 5. SCC-MAC type 4 and type 4, and they're mostly susceptible to non-beta-lactams. And for HA MASA, we can see the SCC-MAC is type 1, 2, and 3. And also for drug sensitivity, for HA MASA, usually there's multi-drug resistance. So this is data collected by Chinese scholar from 2015 to 2017. It collected a lot of MRSA cases or SORS cases. we can see CA massa infection rate is 24%, and also a very popular strain is also listed here, and also for PBL, as well as the different enzyme, etc., like alpha hemolysin, beta hemolysin, etc. These are the virulence factor, and here we can see there's two subunits that compose the PBL virulence factor, and eventually resulting in the killing effect. So the patient, upon first onset, they will have the WBC reduction. I have seen in literature, the degree of WBC reduction is reversibly correlated to the mortality risk. And this is a report from Science. We can see PBL is a cause of necrotizing pneumonia, and also it's a global regulator to regulate the expression of other viral factors. Not all CA massa contain PBL gene. This is actually a epidemiological meta-analysis in China. We can see that among CA massa patients, PBL carrier rate is 42.1%. This is another study about the prognosis of CA massa. Here we can see the median days of survival is 10 days, and mortality rate is very high. So a very heavy disease burden. And here we are looking at the treatment. We have vancomycin, linezolid, and for vancomycin, we need to monitor the kidney function and plasma concentration to adjust the dose. Target concentration is 15 to 20, and linezolid has a very high concentration in lung, and also here we can see it has bone marrow suppression effect. That's a side effect of linezolid, and it might result in thrombocytopenia and also increased lactic acid level. Daptomycin is a bactericide, and it will form an iron tunnel and also have depolarization of cell membrane, have very rapid killing effect of bacteria. So here we don't have evidence to prove the synergistic effect. And for ticacycline and also for the ceftaroline, they are time dependent and need to adjust the dose. And also the longer the bacteremia lasts, basically the mortality risk will increase. And for the bloodstream infection management, here in this literature, there is a recommendation for lung origin bloodstream infection. It's recommended to use linezolid or ceftaroline. And for the soft tissue and skin source, it's recommended to use vancomycin and daptomycin. For combination, we can use daptomycin with the 5th generation of fifth generation of the spirulina, basically ceftaroline, etc. And also about the monitoring of bacteremia, here we can see we've also had the recommendation for persistent MRSA bacteremia. If it's more than 72 hours, it's recommended to use daptomycin and ceftaroline. For daptomycin and linezolid combination in vitro and also in case report, we can see that the combination of both do show synergistic effect.
So here you can see these are the 3 case reports. And also for the mouse pneumonia with the bacteremia patients, we can also combine vancomycin with the linezolid. And also we do have those suggestions. We also see Chinese reports. And so with the two combination, they are able to inhibit Staphylococcus aureus biofilm. And also we see foreign reports saying that for the combination of the two, they don't have synergistic nor antagonist mechanism. So I think this is indeed a very valuable opportunity. I also have a question for combination of the vancomycin with linezolid. What about your view on this combination? So from this case, I also have many important takeaways. Say MRSA has high virulence and with very quick progression, and also they sometimes will have severe pneumonia. And for Vivicamo, we can replace the lung and also to win time to save the severe pneumonia with adequate infection, and adequate drainage is very important. And also we need to have the MDT. This is also critical for the patients. Okay, that's all from me. Thank you very much. Thank you, Professor Song, for your wonderful sharing. So this is a community acquired high virulent MRSA pneumonia. The patient utilized ECMO, and the treatment is successful and is very complex. And we also have some panelists. I also want to give the floor to Professor Carlo and Professor Simon. Any comments?
Yes. First of all, I thank you very much for the clinical case. I have some difficult to understand all the antibiotic therapy, but I understand that there was perform whole genome sequencing of the Staph aureus. So are you able to demonstrate CCMAC cassette 4 and Phantom Valentine gene in whole genome sequencing? Thank you very much.
So, Professor Song, thank you. Thank you, Professor Carroll, for your kind question. So in my slide, I have shared the NGS testing and also in alveolar lavage as well as the bloodstream, we identified the Staphylococcus infection. So we did NGS testing.
Okay, thank you.
So, Professor Lin.
Can you hear me? Sorry. Thank you very much for your presentation. I would like to ask you if you think that linezolid, because of his activity against protein synthesis, could be used as a backbone in the therapy of Staphylococcus aureus producing penton-valentine leukocidin infection, because linezolid is able to reduce the expression of PVL. So what is your opinion about this?
Thank you. Thank you for your question. So for this patient, actually, the patient was administered to our hospital in February. Actually, the patient was changed from vancomycin to linezolid. And in the process of the treatment, the patient has thrombocytopenia. So, and we cannot exclude this was not induced by linezolid. That's why we stopped it, linezolid, for almost 10 days. And on 23rd of February, according to MDT discussion, we reinitiate combination of vancomycin with linezolid. And just like you mentioned, linezolid is backbone therapy for this patient until for like 35 days. So the linezolid has been on for the patient for 35 days.
Thank you very much.
Professor Lin, are you online? Okay. Thank you. Thank you very much for sharing this wonderful case with me. So I'm not an expert of the infection. So in your presentation, I noticed that in VV ECMO, the patient had pneumothorax and the patient had positive pressure ventilation. I think the patient had the severe pneumothorax. So I think this is like a tensor pneumothorax. My question is that how did you identify this? And also originally for the tension pneumothorax, the patient would have high fluctuation of circulation. However, your ECMO is VV ECMO. Therefore, in this situation, the hemodynamics would be hugely fluctuated. But you saved this patient. This is a great success. So I'm just wondering, how did you manage this patient back then? Thank you for your kind question. Actually, for this patient, the patient had decreased oxygen saturation and also had dyspnea and distress. The patient had the circulation issue, and for the lactate, and the patient was also elevated hugely. So the physician on duty called for a CT test, and because upon the mast cell pneumonia diagnosis, the director said that the patient had a high risk for pneumothorax. So that's why we also called the POCT-CT in a very prompt manner, and then we identified the pneumothorax with the drainage for this patient. So because for tension pneumothorax for cardiac surgery department, this is indeed very emergent. We also need to have the emergent treatment because the patient had a positive ventilation. Sometimes we didn't have time to have the thoracic CT, and so you did the CT and also called the thoracic surgeon to do the drainage. So how did you maintain the circulation in this period? So I understand. We did some step-up measures for the circulation for the pneumothorax reason. Our consideration, I think this is related with same as MRSA, and because we have the hollows in the lung for those patients, and we cannot fully exclude the positive pressure ventilation causes. Okay, thank you very much. So now I'd like to hand over to Professor Deng Shen. Thank you very much for your kind question. So for this patient, the patient utilized the CRT and ECMO. So for hemodynamics as well as the metabolism within the body, we will see changes. So my question is that as the pharmacist or from the pharmacy point, have you done the surveillance of the concentration or based on the PMT or TDM? Have you done any adjustment of the drugs? Thank you for your kind question. So I think we are the same as Zhangyang Hospital because for pharmacy department, they would always offer us the support. So for this patient, actually, during vancomycin treatment, we utilized a lot of the TDM to make the adjustment of the doses, and also for other drugs, and also under the support and the guidance of the pharmacy experts, we also made some adjustments. Okay, thank you, Professor Deng. Okay. I want to thank the former panelists for the kind comments. So I think Professor Song also mentioned that way the combination of vancomycin and the nilotinib. And so in reality for this patient, because for Staphylococcus aureus has high virulence, and also the patient has PVL, which is the cytocidal virulence. So the bacteria is not so resistant. It is that the patient has very high virulence, and so I think we need to choose the drugs that have high concentration in the lung. And also when we combine vancomycin with nilotinib, even though we didn't have much experience, but I also noticed that the patient had bloodstream and pulmonary infection. So I think for the combination, maybe we can do that in the future. And Professor Wang, I'm not sure if Professor Wang is still online or not. What's your view on the combination of the two? Because for gram-positive infection, one out of the two is able to make a difference. But nowadays, I understand we can also combine vancomycin with the nilotinib. So I think we are now close to 10 p.m. We're way behind the schedule. So now I will hand over back to our chairperson. So over to Professor Liu. You can give us the final conclusion. So I think for each session, we already have done very good conclusion, and we also have very in-depth discussion. For the interest of the time, I will not give any conclusion remarks because I think for today's discussion, it is very helpful. We find it very helpful to learn from each other because for antibiotics case sharing, the discussion is always going to be very insightful. I'm looking forward to having more discussions with all of you in the future. I want to thank all the distinguished experts for your kind participation. I also want to thank the organizer and sponsor of this event. So Professor Xin, over to you. I don't have the final remarks. I can only share with you my personal feeling. I do have a lot of takeaways. So we had a lot of discussion about the streptococcus, and in the past we focused a lot on the gram-negative infection, and the first case is the SSTI patients, but sometimes it's also very difficult to do the treatment with the drainage as well as the improvement of circulation is very important. Second case is the graft infection as well as the skin infection. And also if we change the graft, the risk is also high. It's also difficult to do the drainage. Therefore, anti-infection and the biofilm is something that we need to deal with. So the treatment is also very success for the AIDS patient. We also have a lot of takeaways, and also we had a lot of takeaways, and Professor Wang also gave us very good insights. And also for the cortisolide as well as the ceftobiprole, we don't have much experience in China, and actually for the treatment duration, and we also have a lot of suggestions. So I think these are all valuable information. And the last case is community-acquired MRSA.
Comparing to hospital-acquired MRSA, it's more difficult to manage because it's usually more virulent. This is a very successful case. And we can see that at the first disease onset, the IL-6 was so high, was very strong inflammatory response. So actually very successful case, very well managed. So there's also proposed a question about combination daptomycin or linezolid or vancomycin and combined with linezolid. So for this kind of difficult to treat MRSA infection, strongly virulent, especially if it's community acquired MRSA, if we are going to have combination, should we use vancomycin combined with linezolid or daptomycin combined with linezolid? So the patient had lung and also bloodstream infection. So do you recommend combination? Professor Wang? For the last case had lung infection, right? It's lung and BSI, bloodstream infection. So generally speaking, daptomycin has a problem with lung or endocarditis and also bloodstream infection. Daptomycin is the best. However, for lung, that's not the case. The linezolid, it has some problem with BSI, but works very well in lung. So for HAP, massa HAP, linezolid is better than vancomycin. So I think there are, for both drugs, they have some disadvantage. Of course, maybe we can start with the vancomycin and later add something. That can be a good option. So about combination of these treatment, we actually are not using combination a lot, only in very special cases. So vancomycin and also some of the, for example, fosfomycin combination, that can be a good option. For endocarditis in the short term, maybe we can use rifampin, oral treatment for the short term. That can also be possible. For me, I think maybe vancomycin and also fosfomycin. But for the three drugs that we talked about before, they are all very expensive, so we need to consider affordability. Thank you, Professor Wang, for the answer. I think we can also try or explore more in the future. Finally, I'd like to invite Professor Wang to summarize. I think now with the Ceftabipro available, Ceftabipro is a very good option as well. So for BSI, bactericides, and also for lung, we can see Ceftabipro works good for lung as well. We also have quinolone. Quinolones basically, I think several of the quinolones works pretty well. So using quinolone sometimes alone, we're not very reassuring, but Ceftabipro is very good. Last year, we have a study about bloodstream infection using Ceftabipro and daptomycin to compare these two drugs and had comparable results. Internationally, we believe that for massa related endocarditis, if Ceftabipro is comparable to daptomycin, then it's a very reliable treatment option. For the previous case, it's actually related to the vascular graft. The reason why I said that we can try to discontinue is because for BSI, the two drugs are comparable. I'm not going to further summarize. Well, Huarun CR Sanjo approached me, and in our annual meeting, we have a US expert did some lecture, and maybe and then we decided to have an international symposium. We don't have any experience before. I think it's actually better than expected. We had several cases, great cases, and also all the participants. Indeed, you have had great contribution, and also for the simultaneous interpretation, it also helps as well. And I would like to especially thank our two Italian experts, great expertise, and also great English, actually. I believe it's because of our jointed efforts so that we can be successful, even though we had like an hour delay. But I think we are basically find it all very fruitful. So maybe we can just conclude today's meeting, right? Yes. Yes, let's conclude today's meeting. Thank you and goodbye. Thank you very much and goodbye. Looking forward to future opportunity to further communicate and exchange.
Bye-bye. Bye-bye, everybody.
Bye-bye. Thank you so
Bye-bye.
much.
Thank you. Very good meeting. Bye-bye.